Let's give it one more minute. At least on my clock here, it's 1 minute to 12. Give it one more minute. Excellent. Thank you. So here we go, the start of our 4-day, very, very special course. Wonderful opportunity. I personally am very excited about this, and I'm sure our audience, hopefully you're looking forward to this as well. So a very warm welcome to all our participants in this admin online course on strategic planning for vector surveillance and control. APMAN, of course, stands for the Asia Pacific Malaria Elimination Network, which is an alliance of 22 member states in Asia Pacific that work together to reach the 2030 goal of malaria elimination. We will not achieve that goal unless we are effective in vector control. And why do I say that? Because ever since Ronald Ross discovered in 1897 that it was Anopheles mosquitoes that transmit malaria, the entire global effort to reduce malaria burden has focused on vector control. At first, the emphasis was on larval source management. Then we moved to DDT spraying in the mid-19th century. And finally, late 19th century, we moved to insecticide-treated nets. I'm generalizing to some extent, but there's largely broad picture that is the true picture. Each year, well over 50% of the malaria budget worldwide goes towards vector control. But effective vector control depends on effective vector surveillance. So we're very fortunate to have an absolute expert available to teach us about all the various elements that go into vector surveillance and control and how to strategically consider these different elements for an effective control approach. He is Dr. Pradeep Kumar Srivastava, who has spent decades working on vector control and developing strategic documents for surveillance and control. But before I introduce Dr. Srivastava, let me quickly say a few things about the webinar process itself. So this online training course will be held each day from today until Thursday, 4 days, starting at 12 noon Bangkok time. There's no waiting for stragglers, unfortunately. We start at 12 noon sharp. Each day, the webinar training session will last about 2.5 hours with a 10-minute comfort break in the middle. At the end of each day's lectures, we will have about 20 minutes of questions and answers. So it's about 2 hours of lectures, and we'll have a 10-minute comfort break, and then about 20 minutes of question time. So 2 hours lecture time, roughly 20 minutes Q&A, and 10 minutes rest break. I want to ask our audience members to please insert your questions in the Q&A box, not the chat box, please. We will only be monitoring the Q&A box for questions. So while Dr. Pradeep is lecturing, please insert any questions that may pop into your mind into the Q&A box. We will get to them at the end of the lectures, at the end of each day. Because the event is in meeting mode, not in webinar mode, everybody is live. So I kindly ask our audience members, please, to make sure your microphone is on mute. Otherwise, we have very distracting background noise of people having conversations and so on. So may I ask, please check that your microphone is on mute. During the Q&A session, we will give you the opportunity to ask your question live if you prefer. For the moment, please put your microphone on mute. Okay, so let's introduce our distinguished expert trainer. Dr. Pradeep Kumar Srivastava was head of the Vector Control and Entomology Division of the National Vector-Borne disease control program in the government of India until his retirement a couple of years ago. He headed the planning and coordination division of the India National Vector-Borne Disease Control Program. He was in charge of urban malaria and the National Filariasis Control Program in India. He has worked as advisor to WHO on many occasions in member countries of the Southeast Asia Regional Office and also WHO headquarters in Geneva. He was a member of the Indian delegation to the Conference of Parties in 2017 for DDT reduction in vector control. He developed the state-specific malaria elimination plan for Jharkhand state with WHO support. That was back in 2019. And he has more than 50 scientific publications to his credit and also many guidelines, including, importantly, the operational manual for integrated vector management in India and chapters in various books. May I ask our audience members to please mute your microphone? He was bestowed the Festegard Franson Award in 2019 by the National Academy of Vector-Borne Diseases in India. He has provided support in vector control needs assessment for India and Timor-Leste as a WHO consultant. He has been a core expert team member for the malaria program review in India for World Health Organization, as well as in drafting the National Strategic Plan for malaria elimination in India, specifically the plan for 2023 to 2027. So I think you'll get the impression that here is a man that has a lot of strategic planning and overall programmatic experience to understand the big picture of how to go about developing and implementing and monitoring surveillance and control programs. And I think you will agree with me, we could not ask for a better person to provide this training. And on behalf of all of us, may I thank Dr. Pradeep for setting aside the time to provide this training. So, Dr. Srivastava, thank you again, and over to you.
Thank you, Leo. Am I audible?
Absolutely. We see you. We hear you clearly. Thank you.
Good morning. Good morning to all. And some people, I mean, we are at 10:30 in India, so it's good morning. But some people in Singapore and other beyond that, so good afternoon. This is definitely a important session, and we are more interested. In fact, I was thinking to start such kind of lecture series with our own association in India and with the program coordination. But it's good that Appman has taken this lead and they have invited. Maybe you would like to hear and learn from all of you during question and answer session, because there may be some more clarifications required. Though the topic itself, it says that it's a vector surveillance mechanism, and we have divided this into the four. Is it visible now?
Yes, it's not full screen, but it's visible.
It's on full screen.
Maybe it's just my screen.
Anybody else who is not visible to see on full screen?
I can see it in full screen.
Okay.
Okay, that's fine. Thank you.
So, though the topic itself, it says that it's basically strategic planning for malaria vector surveillance, but little bit we have to understand on the total elimination concept, and that is why the first day we will restrict on the concept of framing the national strategic plan. Definitely, we will be highlighting more on vector control operations. So let me start without wasting time. I have divided the whole presentation into 7 points. We will be discussing about the concept of elimination, framework, strategic plan component, then vector control planning, then its significance, then vector control components, and then finally elimination certification process. And then as a follow-up of these in detail, it will be on the second session, then follow-up in third session, and then ending with the fourth session. So let us start with the concept. There may be many more experienced people who may be knowing little bit of all these things, but this is definitely for them to update. And there are many, I am seeing on the participants group that there are many new people. So they will be definitely, it will be helpful for them. Now, if you go for the concept, which was actually designed long back, and that is why every time we always say, whenever we talk of malaria elimination, we say that the baseline year is taken as a 2015, because 16 to 2030, it was taken as a global technical strategy. Now, if you look on the concept, the basic concept is for any disease, not for malaria elimination, but we are more focusing on malaria elimination. We are working with a high burden. We are working with the different variations in the disease scenario. So we are actually we were aiming to control the disease. And now from control, we are very happy in public health program that if we are able to consolidate at certain level so that the disease is not a major public health problem. But when the concept of elimination came, so from control, we have to switch over to the elimination thing. In between, there are different phases. So we will not exactly reach. So we should understand what is elimination, and then in between, what are the phases. So in the elimination, when we are targeting of elimination of a disease, that zero indigenous transmission in malaria, and we have to sustain and show the documentary proof. So from control phase, when there is a different variation from high endemic area to moderately endemic area and low endemic area, we are switching over, we are progressing towards achieving the zero indigenous transmission in the area. And here, when we are talking of country level, area becomes basically the whole country. We are not being certified by WHO globally that part of the country is certified for elimination. So in whole of the country, we have to achieve the zero indigenous transmission stage. Now, once we are talking of zero indigenous, there may be from, suppose there are 50 cases per 1,000 population, 400 cases per 1,000 population of malaria, then we can reduce to 10 or 1 or 2, something like that. So on different level, that will come later. So that will come in a phased manner, and that is why our strategic approach also has to be developed in a phased manner. So primarily, we decided that the pre-elimination phase, before touching to zero cases indigenous transmission, we have to achieve less than 1 case per 1,000 population, and that is annually. So in a given area, if the population is 1,000, basically, we have to understand that less than 1 case means maybe in any month, there may not be any case. Maybe one case in any month, because 1 case cannot be divided. So maybe in 12 months, hardly you get only 1 case in some months. And maybe that is the peak transmission. So you have to locate the area, another thing. And then finally, you reach to that area. That is why if you see on this chart, from control to consolidation, then we enter to the pre-elimination. And that is the first program reorientation about the elimination concept. And then when you are approaching towards less than 1 case, then you devote some more time and then you enter the elimination phase. Elimination phase, you say that, yes, you have achieved the elimination phase, zero cases indigenous transmission are locally acquired. But then you have to show that 3 years, there is no relapse, there is no new cases coming. And that is what the second program phase. And then finally, when you prove that, yes, in last ending 3 years, you don't have the cases, that is why you are able to prevent the reintroduction of any malaria case. And that is what is the basic concept, that you have to reach to this place before getting the approaching to WHO for certification. And there is different process that will come later. So this is the basic concept of this. Now, What is basically the principle of this? The basic principle of this is you have to achieve those from control. You are switching over to pre-elimination and elimination. So you have to own that. You have to be very, very responsible and accountable. And that comes only from the good governance and good leadership. We also, when we go to the different states, different areas, we look for and give more focused attention where the governance is better. And then we go on high priority zone with the more number of human resources, or with we don't ignore them where the governance is. So the best governance comes from the good leadership, and that is how the ownership develop. And then once the leadership is there, ownership develop, then only your involvement is meaningful for the participation of start participation with the service providers, and then ultimately it has to the ownership has to be given to the community so that they understand and they own the whole responsibility. Then once that ownership is developed, simultaneously you have to show your efforts, and that is why the elimination efforts are accelerated. Because unless you simultaneously, all these 4 5 points which are given, they are all simultaneous move except the last point. So simultaneous move, you have to have that basic principle is that you cannot wait for one to complete and then go to the second. So simultaneous move according to the principle that you have to accelerate the elimination effort, because there are some minor changes in the strategic approach from control to elimination. And simultaneous efforts means everywhere you cannot have the unique and one strategic approach. So you have to have different kind of intervention, different kind of combination, mix and match strategy you have to add. Then you have to improve its impact. You have to analyze the data, where you are failing, where you are not going. So that is also another component of your whole principle, that you should not keep quiet that, okay, we have started the strategy and we are going through that. So you have to go on stratifying and look for the area where it is responding well. So you have to sustain. Where the area is not responding, you have to change it. So that is why analysis is another MAT principle. Then at later stages, it should be the services should be accessible to everyone. It is not that any demarcation, any discrimination should not be there in the access of the quality health services. And this has to improve slowly, especially during the elimination phase and post-elimination phase, that the health services should be available. People should not forget that, okay, sometimes we had malaria, so there were a lot of people were having for health services. Now it is restricted to 1 or 2 centers. So this, and people should have the access. Innovations in intervention is another principle, that you should be allowed to do the innovations. Definitely, there are some reservation in the last but one bullet, innovation in intervention, because in large public health program, the guidelines are framed and they cross the wider area or the total population. For example, if you take the India, 130 billion people are there, and you can't have the so many innovations allowed at different level. So flexibility is different. Innovative approaches has to be approved within the proper infrastructure. Suddenly innovation, in the name of innovation, you should not introduce something which is not approved or recommended under the national program. So innovation and approval, you have to understand. So innovation in principle is allowed for the intervention, but it should be processed through the institutional mechanism. And then you should have a resilient health system, because that this kind of health system only will support and sustain the overall success. Now, what is the concept? The concept, basically, we have understood the concept and framing, but for all malaria endemic country, the framework which is given is that it was little bit changed from earlier. So the framework says that program actions, where it should focus. Earlier, we were having control. So we were all focusing across the country or across the area, that we have to control, we have to bring down and maintain at certain level. Now we have to little bit make it down below, so that it goes down below and it reaches below 1 per 1,000 population, and then finally zero indigenous transmission. That is what is the basic framework. that we have to focus to reduce the transmission from high to low level, and that level where zero indigenous transmission is there. Then there was another case that we should have the feasibility study for elimination. No, now it is not there. The framework says that no, it should not be. It has been replaced by critical requirement. You should work out, you should do the need assessment immediately, and how to achieve, how to start, and how to maintain the elimination. So there is no way of going back. It has already been framed. It has already been decided. It has already been signed. It has already been accepted. Critical role for information system, that is very, very important, which was little bit flexible in earlier system, but our information system and surveillance mechanism, which is basically a core intervention, that must be given full priority. Without these two priorities, let me be very blunt that we should forget about the elimination. So the major priority should go on the information system and surveillance. And to do this, what we have to do? Immediate earliest planning has to be done. The malaria diagnosis, RDT or light microscopy, foci classification. Foci classification is followed after the case characterization, case findings, case investigation. Then strategy for different transmission intensity. Like for example, if you are doing for transmission intensity, you know where the high transmission is going on. Or there is one example in WHO guidelines that mass survey. Mass survey and treatment, that is earlier also, since 50s we have been doing. But earlier the guidelines were that wherever the cases are given or wherever there is an outbreak, you do the mass survey. You do mass survey and radical treatment. You do mass fever survey. It used to be called as a rapid fever survey, then mass fever survey, then mass radical treatment, MRT, FRT. But now the name has been changed, mass survey and treatment. So you go for, and this is especially more so required in the low endemic area. Once you achieve, you should not miss. The basic principle of MSAT recommended under WHO guidelines is that in low endemic area, you should prioritize mass survey so that you are not able to miss. This is one example. So, but many of the people, they are doing it very nicely, and they have documented it. Like for example, in Indian scenario also, Odisha has published 3 or 4 papers on Daman. That is basically uh, the malaria treatment and accessibility in very, very difficult area. So they have published, and their basic philosophy was, basic principle of action was that they have done mass survey and they have distributed LLI, and then they have intensified their surveillance or not to miss any case. Then another step which is required for the subnational verification of this is so important. Subnational verification, that whichever area you are doing, as I have told in earlier, that whole country has to be certified in one go. It cannot be in a different phased manner, but our activities are in phased manner. So if in any state you are actually narrowing down the area, trying to locate the area where the transmission is still going on, active transmission is going on, so we have to narrow down the area. And for that, subnational verification means the area which is already cleared as per your records and reports. You should try to verify it, and there is a different system for that. So that is another very, very important step that you should start immediately. Then you have to, once you have done subnational verification and combine together for all those states, for all those areas, if the whole country, then you have to follow the process of WHO certification for malaria elimination, which was started in 2017, 19, and then 2022. It has again been, there is a small booklet which has come from WHO. There is a streamlined process. But all these things you have to do, but simultaneously you have to, as I showed you the previous slide, that prevention of re-establishment, which is very, very important. There should not be resurgence, there should not be re-establishment, and for that you have to monitor the any reintroduction of cases or migration or imported cases. Now, with this concept, let us go to the framework of the elimination. if you look this chart, it looks very, very complex chart. Those people who knows me, it takes little time to make it. But if you see the malaria elimination, what is the basic framework? We have to have the strategy. We have to have a principle in practice. It is not principle should not be on this. We have to have management and planning. Then we have to have research inputs. Then simultaneously we should go for, after doing all these things, we should have a certification, and then we should have the knowledge of prevention of re-establishment. Now, if you look for one by one, what says that management and planning? Initially, we have agreed on the principle that about the first who has to understanding malaria transmission dynamics in different area, different scenario, different eco-geographical condition, with the environmental factors, with all those. Earlier it was triad, now it is quadrat. So parasite, vector, human being, then environment. And then once we understand that, what is our target, whether it is aligned with global elimination goal, or we expect that we will not be able to achieve, or we expect that prior to that goal we will be able to achieve. So we have to target according to our own infrastructure, but we should try aligning with the global elimination. Currently, it is aligned with the Sustainable Development Goal by 2030. And we have actually targeted for 27, because the 3 years of this POR policy and re-establishment and sustenance period certification process. So once we agree on this principle and we approve these principles, we should develop simultaneously strategy, and simultaneously we should strengthen our management and planning. So management and planning starts with national level committees. Then we should address them about the planning process. We should tell that the decisions will be basically on informed, and informed decision means every decision will be informed based on the evidence generated during the course of time. If there is any change is warranted, it will be taken. Management planning, another important portion is supply chain. Logistics should never be an obstacle. Whatever comes, if it comes, I can give one example. When Metro Rail Corporation was established, there was, whenever you construct or you go across the construction site, there is always a hurdle. Some people will go, some people land will go, some people building will go, some road will go. So many stakeholders come in between. Either they will request for compensation, or they will seek the legal advice. So that will delay the process. But when the Metro Rail Corporation started, there was a blanket approval taken that whosoever comes in between, all those things will be met by the corporation, and there should not be any obstruction. So they have given heavy compensation, and it was all approved. So logistics has to be managed properly. Logistics has to be managed properly, and it should not be an obstacle, basically. The structure has to be, to do this planning process and this, there should be an institutional structure. Where should go? Where the program person should go if he wants or she wants to seek some advice or some approval. What structure is actually governing the whole system? And then the environment should be made properly. It should be enabling environment. These are basic concept of the management and planning framework. Once we do simultaneously, we are here, the technical people, they are developing the strategy, and the strategy starts that first thing we should mind that we have to accelerate the process, whatever we have been doing in the control operations. But to do that, where to go, which strategy? We should do the stratification. Where and what we should do, which strategy we adopt. Basically, there are only two strategies. One, you have to do parasite control, and second, you have to do the vector control to interrupt the transmission. To do this, you have to take a lot of participation. One person cannot do it, or one department cannot do it. So you have to take supportive intervention. That is where the capacity building, human resource, training, intersectoral collaborations, stakeholders, partners collaboration, community mobilization, all those things comes. But basically, these two strategy has to be framed for different area. It can be different for forest, it can be different for tribals, it can be different for the urban settings, it can be different for different transmission intensity, where the high transmission, where the moderate transmission. So different geographical, different transmission potentials and different settings of during the process of achievement. It has to be, so a strategy has to be framed very nicely and it should be explained. Then only it can be accelerated. Now, the basic, as I was telling, that acceleration when you are doing, the first thing is that surveillance. Surveillance, when we talk, it comes to the mind that surveillance means parasitological surveillance. No. Surveillance means, to my knowledge or my experience, surveillance includes both the pillars. Because one leg you cannot stand forever. You have to have 2 legs. So surveillance has to be both-legged, epidemiological surveillance and entomological surveillance. So please make it, whenever you are making any plan, strategic plan, give priority to all. It should not be that you devote 2 hours for epidemiological surveillance and then 10 minutes you finish off the entomological surveillance. Absolutely not. It is not going to work, and we are going to face this after a long time. So surveillance has to be accelerated, both epidemiological and entomological. In that, because we are mainly dependent on the prioritization and stratification, so initially when we are shifting from control to elimination, we have to depend on the number of cases and endemicity. So case detection and management is another important part. And simultaneously, if you look on this bridge, enhancing the vector control operation, because entomological surveillance guidance will lead to which vector control options available within the available vector control operations, which one is better to best suited in that particular area. We will be coming on that, because that will be then. And this stratification, when we started, this stratification will again be done. It will be done so that we know that how much area we have actually narrowed down. And that is why we will take the input of the research simultaneously, whether our entomological surveillance or parasitological surveillance, do we need something extra to be done? And this output of this operational research, it should be very important point that it should be done quickly. It should be shared quickly. It should not be delayed for some institutional setup or some publication or some documentation, so that it is given to the regulatory bodies, and regulatory environment for malaria elimination should be also strengthened, and they should take the cognizance of these outputs of the operational research. Once these are done and these are embedded in our strategic approach, that is what is basically innovation, innovative approach with this kind of research, this kind of operational research output, and this kind of innovative approaches are included through the regulatory bodies. Then what we are talking about, the total strategic program governance and principle agreed, then only we can get the output, and this will be leading to us for certification. But before certification, WHO certification for malaria elimination, to adopt this, we have to have the subnational verification. And then we have to, later on, once we enter in the prevention of reestablishment, just elimination and post-elimination phase, we have to look for the risk area. Risk area, basically, we will be describing, but here let me tell you that risk area is basically when there will be very less cases or there will be no case. So we have to look for whether the area is conducive. So vulnerability and receptivity in that particular area, we have to look for this. And then our health system should maintain, go on according the priority to the malaria, and it should be integrated properly. Just for namesake, it should not be integrated with the general health services. This kind of framework, it has been described also in the global technical strategy when it was framed in 1630, WHO global technical strategy, which has been the basis for all the framing of the strategic plan. See, this also says that 3 pillars, if you look on this, the first pillar says that ensure universal access. Means everybody is to have the access. Nobody should be denied for malaria prevention and treatment and cure and this kind of services which are being provided. acceleration of the efforts, that is very important. I have already explained. And then surveillance, which I have told that surveillance, the whole surveillance, both epidemiological and entomological surveillance should be taken as a core intervention. In fact, later on, 2022, I think there is a full booklet on surveillance and monitoring and evaluation, blue color book. It has come, which has whole of the book has emphasized that how the surveillance should be done. Then there are some kind of supporting elements, and that is what is innovations and expanding research. This is very, very important, very, very important. And the second one was the enabling environment. This is again the important chapter which has come in the global technical strategy, and that has taken the base. Now, if you look on this, what it says basically says same thing. You have to ensure the access, first pillar, with high coverage. Everybody should be allowed to have the prevention strategy, diagnosis. Not that we will not spray your house and we will spray, or one particular sector, one particular community is aware of this kind of thing. If at all it goes on the basis of documentary evidence, it should be made available. They should be informed that our decision is because of these reasons. It is not that just because of some kind of discrimination we are living with. And then acceleration, and then transfer malaria. Then supporting element, which I have already explained you, that action to facilitate rapid action, immediate research. So, and the research inputs, all the research inputs are not taken because it is not cost effective sometimes. But we have to, sometimes we have to bypass, we have to justify that though it may be not cost effective at that particular time, but it will be, for long term, it will be much beneficial. So we have to work out that. And supporting element 2 is strengthening the enabling environment, and that is start from the top level: governance, political commitment, multi-sectoral approach. Enabling environment also says that if there are multi-sectors involvement, there should be accountability, and responsibility should also be shared with them. They should not only come for the meeting purposes. So we have to make such environment so that they come forward and they take ownership, and that is very, very important in the supporting and enabling environment. Now, the global technical strategy, which was framed long back, 2016, for up to 30. Now, what they have set some target, and WHO has almost achieved that target. By 2020, their target, they set up 4 targets, and the red line marked, if you see on this. Somebody is using pen. Somebody is using pen. That is why the marks are coming. So, if you look on the 3rd and 4th, the first 1 and 2 will reduce malaria mortality globally and reduce malaria case incidence globally. More than 40% reduction by 2020. It is gone. 25, more than 75% or 75% both. And then 90% more than that. So still we feel that 10% cases will be there globally by the end of 2030. But if you look on the 3rd and 4th targets, what milestones were set, that by 2020, at least 10 countries, at least 20 countries. Now I believe that there are 17 countries, they have already been declared. Though there are very, very small countries, but there are at least 35 countries should be there by, and 25, the target was that at least 20 countries should be declared, should eliminate, should substantiate their document that yes, they have eliminated. And these countries, they should simultaneously, they should, whosoever goes for elimination, they should do the prevention of, and they should may I request to tell them to stop their mic, mute their mic, sorry.
Yes, thank you, Dr. Pradeep. May I again remind our audience, you may not always be aware that your microphone is unmuted. Please just check that your microphone is muted. It's very distracting if there's background conversation while Dr. Pradeep is trying to give us the lecture. Please, everyone, let's try and respect that request just to mute your microphones.
Thank you. Thank you, Leo. Thank you very much. So the fourth point is that prevention of re-establishment, it's not only you do something, you have to show that, yes, you have prevented it. So the documentary evidence has to be shown, and that will come only when you, every year after the year after year, you are showing that there is no re-establishment of even a single malaria case in that area. Now, if you look on this, while setting the target, what was the advice given by the WHO? This is basically for all the countries that they should work out towards the ultimate goal of malaria. As I told you, this is already signed, this is already decided. So there is no question of going back that we will not eliminate malaria. We have to eliminate malaria. So it is regardless of their malaria burden, everybody has to set right this goal. And only thing we have to set right the strategic approach. We have to frame our strategic plan like that. The previous concept has been changed, and this will be seen in the next slide. This is the slide which, how to remove these? Sorry. Anyway. So, if this slide you see, 2007 strategy and 2007. 2007 is the strategy when basic concept was being designed. And 2016 when global technical strategy came in between. So basically 2007, this last four, left side four, if you look on this, feasibility of elimination, we have to do. Limited countries, we will start based on their feasibility studies. They will do the focus classification for site classification, and then they will start the elimination strategy. But the whole thing was conceptualized and then it was changed, because basically our whole target was control to consolidation to elimination and then maintenance. Now, this whole strategy has been changed. So critical for all the nations, that is what is important. Process monitoring has to be very, very vigilantly monitored. It has to, unless you do the process monitoring, last minute, everybody will come and say that, okay, you have not done because of this only malaria outbreak or zero indigenous case you could not achieve. So if something was to be done in the month of January as per strategic plan, February, whether you have done it or not and why you have not done. So you should have the important notice, alert signals that this is what is, we have process was supposed to be done in this particular time, we have to do it. Simplified focus classification was made, which was very, very little more elaborate during earlier years. Now its focus classification has been simplified definition. Flexibility has been allowed in the 2016, that definitely through the institutional mechanism, but flexibility is allowed. It is not very rigid. And then a strategy for different transmission season, different transmission intensity. You can choose one or two, and that is what the role of integrated vector management will come. That is what is that. Before we proceed further, just this slide is very, very important, and just keep in mind, and it will come again and again. Sometimes more definitions will come. May I request Mr. Salman Mukhtar that please switch off your video also and mic. So malaria elimination, basically when we are targeting for the reduction to zero level incidence, indigenous cases locally, what is the definition? Definition you must keep in mind that definition of indigenous case is that malaria parasite species in a defined geographic area as a result of deliberate efforts. It is not that it was already there. So you have done some efforts, and this continued measure has allowed to prevent the re-establishment, and now there is no indigenous cases locally acquired. And that is what the definition will be. And this is what the documentary evidence has to be produced every time whenever you go for certification. So that is why this slide is very, very important. And then the another important slide which has come, that if you look on this slide, that what is the metrics, indicative metrics for the distance. We started with high. Say for example, it is an indicative metric. Say for example, our target is to bring our target is to bring to 0. And then before that, we have to do pre-elimination. But say, for example, if we have started more than 450 cases, just an indicative 450 cases per 1,000 population API annually. So it becomes 450. You cannot go directly here. That's what I was explaining earlier also. So in between, what is there? You have to go reduce. So you have reduced to the moderate level from 450 to 0. Your moderate level comes 250 to 450. It is again, I am reminding, it is an indicative thing. And then again, you have to do for API further reduction to 100 to 250 cases. Then you go for less than 100 cases. And then you go for less than 1 cases. And then you go for 0 cases. So this is different color intensity showing that you are in a phased manner you are approaching. And this was done in 2016. We have already crossed 7 years. Because most of the countries, they framed their strategic plan for 5 years they are made. So 17 to 22 it was framed after the 2016 strategic approach. What was the strategic approach in between? What was the intervention suggested for that? If you look for this ABCD, basically it is an ABCD. If you look for the WHO guidance document, so component A, you have to enhance and optimize. Slowly, I am coming now vector surveillance and focusing on the strategic planning for vector control. So you have to enhance the optimizing vector control, the last line down below line. Then you have to be watchful. After you have enhanced the universal access and universal vector control, then you have to enhance simultaneously because number of cases will be less. Number of cases, once it is less, you have to enhance and optimizing the case management. You have to listing, you have to do the testing, you have to treating, you have to track, you have to follow up the individual cases because the case load will be very, very less. Once the case load is less, then you have to enter into the second phase, that is your sensitivity. Surveillance system should be very, very sensitive and very, very specific. It is, we have heard about sensitivity and specificity for some diagnostic tools or some tools and technology, whether it is specific or like, for example, when we do for vaccination, we see the sensitivity and specificity. We do the rapid test for malaria, we ask for the sensitivity and specificity. System is also to be sensitive. System is also to be very specific. You can't have suddenly call a leprosy technician who is trained for leprosy, not trained for malaria, and send him to go for doing the test of malaria. So that does not mean that your system is very specific. So what is required is you have to very, very sensitive, your system, your tools, your technology, everything has to be very, very specific and very, very sensitive because your number of cases will be less. And our target is not even single case. So that is what is the B says, that the second step is specificity and sensitivity of the system and your technology and tool, even the monitoring. Then you go for the next, that entire population, different sects, different groups, different areas. Population wide, there should be parasite clearance. It should not be overall average, that our whole district is 0. That is what, when we were doing strategic planning, we said that the country should be divided into state, and states are stratified based on category, different categories, 1 to high, moderate, and low. Then you should have further division in the district to the sub-district level. Then the sub-district should be divided into the PHC, primary health center, or the village level, whatever system in different countries are there. So they should stratify. Okay. So in this particular PHC, primary health center, so say we have 10 villages, out of 10, 9 are green, only 1 is red. Why it is red? So we should be very, very watchful, and entire population wide there should be complete parasite clearance. Then the last is the D is the basically you have to investigate. If you get very, very less number of cases, even a single case, you have to rush immediately. You have to do the case investigation. And after doing case investigation, look for the area And that foci, if there is a more cases, that foci has to be investigated, and the entire foci where the case was found, it has to be cleared. So from general, you are enhancing your entire strategic approach for vector control, for case management, parasite clearance, different groups, different area, different population. And when you go to the very less number, you go for individual case follow-up, testing, tracking, and treating. And then you are checking one individual cases, investigating the region, the case, the follow-up, and then the entire foci you are clearing. Then only this is looking the eyes for elimination and documentation. Then only you can do and maintain it. That is what is given here. A, B, C, D, enhancing and optimizing vector control and case management. B is increasing the sensitivity of the surveillance system, and then accelerating transmission reduction, and then investigating and clearing all the individual cases. So this is, as I told you, this is mix and match of experience, WHO guidance, some national guidelines, everything is there, mix and match. So now if you look on this, I'm just giving one example of stratification, though it is little more complex to do it, but it is easy when we understand this. See, if you are doing stratification, which is the first step of starting the amplification or enhancing our strategic approach, you may find by virtue of experience, without any technical things, you are seeing that the area is receptive or non-receptive. The first portion of stratification, that this area is conducive, okay, mosquito breeding will be there or not. So the area is receptive or non-receptive. Now, once you do further stratification, you see non-receptive is okay. There is no mosquito, there is no chance, like high altitude, all snow-clad mountains. But in the receptive area, when you do the analysis, you will find that there are some receptive area where no malaria, where malaria is not there. But there are certain area which is receptive, but there are malaria cases. Now you have to look for this area. Now further, if you go on and do this stratification, in this you start collecting the data, then you will see that, okay, in this area also further division, there are some places where malaria without any defined foci, because there is one case of malaria, two cases of malaria. But there are some places where there is persistent transmission going on, or there are more number of cases. So there may be active foci of malaria. Or there are children who are having young age or infant, they are showing malaria parasite. So there are active foci running. Now, if you further go on this investigation for stratification, then you will find that this entire area, which was receptive earlier, it has been divided into three. There is one area which is known as low transmission area. You will find very, very less number of cases. There are some area with a little few, very low transmission, which is maybe one or two cases you will find. But there are some cases where the active foci was running. In that active foci, you will find that, okay, there were some foci where cases were there earlier. But now that foci has been cleared, it has been checked, it has been already cleared. This is very, very important for stratification. Suddenly, we should not start doing the API stratification or case stratification or PF% stratification, something like that. Now, when we do this kind of analysis, we will land up in such situation. When we will land up in such situation, please make it a point. An important slogan is that if arrowhead is missing the target, if you are hitting with something with the arrow, if arrowhead is missing the target, arrow is missing the head of the target, you will never be able to hit the tail. So you will never be able to reach to the end, basically. Same way, in battle against malaria elimination, if you look on this, a few portion of foci, as I have told you in previous slide, they are which are supposed to be hot spot, it should be targeted. If we neglect them, if we try to hide them, if we try to not report to them, we will not go to the field, whatever it is. Maybe there are, if something is not done, there are plenty of excuses. But if it is not done, it will be lead to very, very costly cases. And it will be very, very difficult to change it. And we will end up. So that is what just a slogan I just wanted to tell you to draw your attention. But when we do the kind of data collection and narrow down and analyze the situation for stratification, we may land up like we have seen active foci. The definition will come later. Residual non-active foci, I mean the foci which has been cleared and there is no active transmission going on. There is foci which has been cleared, but they are receptive, means there are presence of some vectors. There are foci which has cleared, but they have become completely non-receptive. I mean, there is no chance of any anopheline breeding, or they are not conducive environment is there for vector also. So the parasite is cleared, vector portion is gone. So this is completely clear. In between, these are the four classifications, very, very important for us. There are many, many more, which we go later. And then these three, which as I have just marked red, we should not forget that indigenous case also, imported case also. There may be, by and large, in program settings, when we don't go for much more case classification. Though it is written in the pro forma given from the program side also, from the WHO side also, there are induced, there are indigenous, there are import, there are introduced. But basically, when we go for the program side, we go basically indigenous or imported. And then the starts that whose responsibility is this and how to monitor, how to tackle this. So that is why I have given that unclassified. If there are different definitions for 4-5 case classification, case characterization, whether it is indigenous, imported, induced, introduced, relapse, recrudescence, even if sometimes you are not able to collect the full information, and then based on those information, you are not able to that, you do it unclassified case, which is actually not given many of the documents. But if you read thoroughly the surveillance monitoring tool guidelines, in there at one place it is given what it says that that is why I have given this quote here, that if the evidence is unclear, the classification that reflects more local transmission. This is very, very important. It's a hidden times. You must understand this, that it reflects more local transmission and should be assigned. For example, cases should be classified as introduced or indigenous rather than imported. So maybe because of indigenous case from one area, it has been introduced. Because of imported cases, the first case which has been established, that is an introduced cases. So the guideline says that it should be taken as a either local, indigenous or introduced cases. Don't try to put it in imported. This is a very important point which I just wanted to highlight during this program. Now, based on so much variations which we have seen across the earlier slides which we have been discussing, if you look on this, there is no one size which fits for all these strategic approaches. That is why the national program should determine, all the national program, different countries who are sitting here, that we should stratify based on the clear understanding. We should have epidemiology, ecology, social features, social determinants. Social determinants will take climate, environment, human behavior, animal population, behavior of the animal and population density, but together everything becomes the social determinants and epidemiological and ecological things. We should take it. And then definitely we will have the malaria cases, so that it will be transmission intensity. Transmission intensity without vectors, if we want to measure, it is by and large, it is taken as an annual parasite incidence or malaria case incidence. But once it is taken with the entomological parameter, this becomes little more complex. So when first time you are doing, you should look for the where the transmission is more or where the number of cases are more. And then accordingly, you should plan the intervention, which we'll be talking in a minute. Fourth point is that vector control planning. The vector control planning, now we have understood about that. We are not talking more on the parasitological or epidemiological planning, because the whole course is revolving around the vector surveillance for the malaria elimination. So we will be discussing more on vector control planning. Let me clarify one thing very important, and which I have been discussing across the different platform whenever I was in the chair, and I have been going to the WHO headquarters also for different capacity. Per se, entomologists and vector control are two different entities. Entomologist can be vector control expert. Vector control can be to some extent entomologist, but for all purposes, he cannot be a perfect entomologist if he has not taken the full degree of entomology. He can do some work on entomology. He can collect the mosquitoes. He can dissect the mosquitoes. But if you start talking of the which group, which parasite, what is the total biodynamic, what are the frequent biting time, I mean, this will be a little more difficult for them. So entomologist's role for entomological surveillance, very, very important. And that is why when you are doing for entomological surveillance, you should not compromise with the qualification of entomologist. The basic job is vector surveillance. They should use their own entomological intelligence for 2 years, whatever they study in masters or during their graduation or during their doctorate, PhD. They should be able to correlate the data, whatever their findings with the entomology, and they should have the correlation with the epidemiological things, and they should be able to predict that, look here, if these things are done, this will be, the output will be like this. If these things are not done, the output will be like this. Number one. Number two, if these things are there, epidemiological data, what do you anticipate in next 5 months, 6 months, 10 months, based on your seasonality, your trend analysis, your decadal trend analysis, that, okay, next 2-3 years, what are the situation going to have if the other things are not maintained or sustained properly. That is the role of the entomologist. They should be able to advise, and their advice should be heard during the planning. They should be part of the policy framing. That is why in one of the WHO document, when there was a foci classification and foci investigation, it is very clearly written, entomology should mandatorily be a part of the foci investigation. This is very, very important line. Monitoring and evaluation. So entomologist has to be a part of monitoring evaluation. Usually you see monitoring and evaluation consultants are hired, or monitoring evaluation experts are hired with the degree of medical graduation. They are good, they are public health experts, but they may be more better if they are also having a parallel entomologist expert as a monitoring and evaluation. So 1 and 1 plus 1 will become 11, not 2. Vector control. Vector control experts, to my mind, it is basically for implementation of the tools, logistics, supervision, field guidance, and reporting. So they have to implement the design, the tools. They can have innovations in their tools. They can monitor the logistics. They can do the supervision. They can supervise the implementation, whether it is spray, whether it is a LLIN, whether it is a larviciding, whether it is a source reduction, whether it is an environmental manipulation modification. So there they should be responsible. One person, you give both the responsibility, that you go and collect the mosquito and dissect it and see the daily survival and the longevity and so on and so forth. There are 26, 27 parameters, total 32 parameters if you take other vector-borne diseases. So, and then when he will do the supervision, when he will do the implementation, when he will do the field guidance, when he will do the reporting, that will be very, very difficult for a person. So that is why I always insist that entomology should be part of the entomological surveillance, which is the core intervention. Now, vector control planning, when you do, like one chart I showed you, that when you are making a strategic plan, so what should be done? When you are making a vector control plan, one chapter of the total strategic plan, then what should be there? If you see, same thing, vector control planning, there should be policy. With what we are doing vector control planning? There is a policy of vector control. If it is not there, you should have a policy. There should be commitment. So initially you have to have policy commitment, and then you have to have advocacy, and then you should have its evidence generated. Based on that, you should be able to convince. Then you should interact with whom you are making. You should, when you are making the vector control, you should invite entomologists, vector control, see the right one, the top right one, vector control, entomologists, vector control experts, policy makers, and implementers. Don't leave anyone, because you have to hear for the field implementers also. So you should have and that is what is bottoms up approach. It is not a top down approach. So you have to involve everyone, then you make the vector control plan. Then how you will be doing? You should tell them, the left one, the bottom one, how you are doing. You have to do the situation analysis. You have to do the vector control need assessment. If you, especially for vector control plan, we should have a vector control need assessment. In fact, I was fortunate enough to develop vector control need assessment document for WHO for 2 countries, for India as well as for the Timor-Leste. I am based on those experiences. I am telling that vector control need assessment is the key point for making a vector control plan. Should not be limited only to the document and circulation and bring down. It is not a guidelines. It is basically a tool for the assessment of vector control. Then there are guidelines you should follow, which way you are going to proceed the vector control and how you are maintaining the quality assurance for the vector control operations. Somebody asked the vector control operation, what are the quality measures? There are many quality measures, supervision checks for IRS, right from the logistics, manufacturing of the insecticide, quality control, dispatch. So there are 3 steps basically: quality check, quality control, and then quality assurance. So the supervision, quality assurance, in fact, it combines all the 3. And there should be very, very importantly, LLIN, whether the people are using it, distribution is proper, the disposal of the bags or the cover is proper, the people who are taking the LLIN, whether they are complaining any itching or something like that or irritation. I mean, these are all quality things which have to be monitored during the whole process. Then this situation analysis and vector control needs analysis, how are you doing? With what measures? The right one, the bottom one, if you see the box. Entomological surveillance. This is another red color, it's very, very important. And then doing the data analysis, and then you are doing the rapid survey, and then you are taking up the whole measure in a package, which is basically known as IVM. Integrated vector management, which in fact I will be talking much in detail later on. With this kind of measures, process, taking everybody into the confidence, you are putting the inputs for the vector control plan document, that what are the resources required, how you will develop the skill, what are the tools you required, what kind of power you require to institute it, to implement it. Then this document, when you submit and get it approved, then you see the right one. Then only you expect the output that there will be no transmission, there will be vector infectivity also will be 0. And once the vector infectivity in that area is 0 and case load is 0, then there is no chance of re-establishment. Then you can surely say that it is prevented. So this should have the knowledge of this, that vector control, we have to have a different kind of settings, vector control plan for pre-elimination, elimination, post-elimination settings. You should have this full knowledge of the biology and behavior of the vectors, total dynamics. In fact, you should have the full kind of process monitoring for vector control. You should have the efficacy, whatever tools you are using, how efficacious they are, what is the quality assurance, whether your quality assurance mechanism is in place or not. Then, I mean, all these things should be part of the plan, and how are you going to do it? And then how are you interpreting the entomological, epidemiological data? So your reporting inputs, then your feedback mechanism, your analysis in between, your feedback mechanism, that kind of bridge should be established, and how you will do it, that should be a part of your vector control plans. So to facilitate the programmatic decision, this is very, very important before you start the elimination campaign. Or now it is actually, we are running in 2023. So most of the countries, they are finalizing, or they are at the final stage of their national plan, strategic plan for 23 to 27, because 2030 is the goal. There is no question of going back. And then the another plan should be, part of the plan should be that elimination setting you should have these important things, that how are you going to identify the case and foci, how are you going to track them? How are you going to treat them? How are you going to make the testing them? So case and foci both you are identifying and then you are investigating. So the whole process should be given and that should come in the elimination setting. Then how are you going to manage all kind of transmission foci? Any transmission which is going on, how are you going to manage? And then whether prompt vector control tools you are having, how are you ensuring, how are you trying to manage, how are you ensuring, this should be a part of your document, that how are you, what will be the process adopted in your country or in your system, existing system, that you ensure that vector control tools are available, so that, because ultimately if you look back on 137 strategy, so within 1 day all cases should be diagnosed and given, and within 3 days it should be investigated, and within 7 days all the measures should be taken, everything should be resolved. So if you have that basic concept in that, so unless suppose something happens in one district remotely 200 kilometers away, and then your tools are available in headquarter, state headquarter at 200 kilometers away, you can't reach immediately. So forget about that 137 strategy. So having that in mind, how are you going to ensure, which are the major area where you are going to store all your equipments, all your things, to do that? That is very, very important uh, tools, process which you should reflect in your strategic plan. Now, if the transmission has been interrupted, then what major points you should have the consideration in the mind? If transmission has been interrupted, you don't expect cases. You have claimed that transmission has been interrupted. So if you don't expect the cases, what are you going to look for? And you say the transmission has been interrupted, it means there is no vector, possibility of the vectors or the infections in the vector. So what are you going to look for? The priority will go for receptivity, whether the area, the ecosystem in that particular area is suitable for the malaria transmission or not. Because sometimes vector is introduced, sometimes the case is introduced. So whether this combination will give a boost to re-establishing the malaria cases, then the re-establishing of the transmission. So this is very, very important in the area which you are declaring that transmission has been interrupted. And then vulnerability. Vulnerability is so important that if in cross-border area, whether it is a national level, international level, within the districts or within the boundary area, if people are coming from endemic area, I can give one example. If you go to the area, say for example, in southern India, if you look for the Pondicherry, which is on one corner where there is no malaria case, or you go for the Lakshadweep Island where there is no malaria, indigenous transmission is going on. And then, but people are moving by ship or by air, they are coming to Kerala. Kerala is already low endemic area. Low endemic area, but there are chances that if migratory population are coming, they can have some kind of things. If they are coming to high burden area, they are coming to Karnataka, they are coming to the Rameshwaram Island, which is there is more malaria cases. They are coming to Chennai, which is more malaria area. So there are probability that they may contract the disease here. They can go as an imported malaria case. They can have the infection. And if the vector is there, then there will be lot of this thing will be there. So the purpose is that if the cases are not there, you have already claimed the transmission has been interrupted. So please look for receptivity of the area, ecosystem is receptive, conducive for malaria transmission, and vulnerability of the population migration and transportation of the mosquitoes, which is nowadays very, very easy. Even in plane, you see a lot of mosquitoes. So I mean, they can be transported anywhere. So you have to look, at least you have to look. And to do the vulnerability monitoring, you have to have it developed with the intersectoral collaboration with different partners, different agencies which are looking at the different area, so that we can go for reporting that this area is now under risk, which I was showing in the last slide as a red mark area. There is another setting which is nowadays, this slide I have added because Nowadays, a lot of talk is going on Stephensite invasion, which is primarily an urban vector area. The mosquito breeds, try to breed in fresh water, stored water, like Aedes aegypti, the vector of dengue. So urban area starts promoting the flaring up of Stephensite breeding because of construction. So what we have to consider when we are making the plan, we have to consider that different rural areas, rapid urbanization is taking place. The transmission dynamics is different in urban areas. You know, for Stephensite transmitted malaria, there are micro geographic determinants. For example, it is very unique in the urban system. Why? For example, you are doing multi-storied building. You don't know where the Stephensite is hiding, where it is breeding. There are certain VIP areas you are not allowed to enter. There are further high security zone VVIPs area. There may be lot of plantation. There may be lot of pond. There are many people who are working for that area, but the health authorities or the vector control department are not allowed to enter. The entomologists are not allowed to enter. You don't know what is the, and that makes a microclimate, micro geographic area. Within the micro geographic area, there will be microclimatic condition within the houses, within the bungalow, within the courtyard, within the park, within the small lawns. There will be microclimate where there is different, and when there will be infectivity will increase, there will be havoc. There are defense area, there are certain secret areas, there are certain high secured zones. You are not allowed to enter. So what you have to do? So these are the things. How are we going to tackle those areas? Especially when we were doing for airport survey for Aedes survey, international airports, we have found lot of breeding everywhere. So there are how to make this kind of vigilant approach. Whom are we going to involve? Whether we are telling them advocacy and they are hiring their own staff and they are doing it and they are reporting us. Okay, it is all right that we are not allowed to enter. But if we can train the people regular basis, so there are different ways which we have to highlight in our strategic plan when we are making this whole course is designed to make how to make the strategic plan. Then multidimensional and multi-sectoral response. That is what I have been discussing. There are different societies, there are different clubs, even in the private clubs, recreation clubs, different hotels, you are not allowed to enter. Just like that you can, I have come as I am a health inspector or I am an insect collector and I am an entomologist. I want to check your hotel for mosquito collection. There you are not allowed. So these are the things. So that is why, and we have to justify that these situations are usually focal. So we have to have a different tailored approach for them. We have to involve them. Certain area where we cannot do, we have to develop a PPP model. So the strategic plan should tell how are we going to develop a PPP model in different areas. There are urban areas, there are tribal areas, there are different areas, there are very difficult areas. Then if there is one thing that there are legal measures are to be also taken. Beside technical guidance and resource mobilization and influx of population, legal measures. In that, usually what we do, we take the old copies and try to modify and then submit it. But we have to educate, we have to do advocacy for the legal department. We have to highlight the advocates and the judges and the legal department through their own institutional setup that look here, this is the problem and unless you do it. Otherwise, what happens? Whatever you submit, this is not approved. Or it is approved also with a little bit concessional amount. So that will not help you in controlling the urban sectors, this kind of population growth of the mosquitoes, which are actually being facilitated by the creation of the urbanization or the contractors or the building builders or even the house owners who are constructing their own house or the engineers who are not fully aware about what they are doing it, that is actually creating a lot of breeding sites. So then we are coming to the significance of this. Dr. Leo, you wanted to have a break in between?
Yes, please, Pradeep. So whenever you think it's convenient, a convenient point, I think we're about at that point. I can feel my own concentration. I'm
I
starting to
think so.
struggle a bit. So I
I
think
think
this might be an appropriate point. Why don't we break for 10 minutes, allow people stretch
okay,
their legs.
okay. Absolutely
Pradeep,
fine.
yeah, wonderful, 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 wonderful logical flow to the subject matter, very clearly explained. I like it, and I'm sure the audience also likes it. But let's all take a 10-minute break, reconvene in 10 minutes, go stretch your legs, go to the bathroom, come back
Okay.
ready for another session by our expert, Dr. Pradeep. We look forward to that, Pradeep. Thank you.
Thank you. Thank you. Resume after 10 minutes. Okay, fine. Fine. By the time people can think of their mind for some clarification if they want. Thank you very much.
Excellent. There are some people raising their hands. Let's leave Q&A for until after the next session.
Okay. Is it okay?
Can't see your screen. See your picture, but not any presentation, Pradeep. There we go. Okay, back on track. Thank you. Please proceed.
So we have finished up to the concept, framework, strategic planning component, and vector control planning. Now we are coming to significance. What is the significance? And we are actually on the vector control. What is the significance basically? Significance of what? Significance of basically we are talking of surveillance, we are talking of response mechanism, we are talking of preventions. So when we are planning, we should also highlight in the document when we are formulating the strategic plan, we should highlight that if we are doing surveillance, in the surveillance chapter, we should highlight the surveillance is not meaning to only restricting to the epidemiological area, but in fact, it is restricting to it is open for both epidemiological and entomological. And it strengthens basically the total network. Not only strengthens, it is strengthened how there are so many ways of capacity building, advocacy, sensitization, intersectoral meeting, interpersonal discussions, interpersonal communications, IPC, what you say. So, and basically it should be whenever we are discussing this platform which are make for the intersectoral coordination meetings, we should talk of the surveillance on vector surveillance precisely. Most of the time what happens, people they don't understand at high level, at the policy level or the administrative level, they don't understand what is entomological surveillance. You tell that mosquito surveillance or vector surveillance, they may understand, or pathogen surveillance. So detection, like you are doing parasite detection, you are doing blood test, everybody understands. Same way you should have the vector surveillance, their detection, and then how they are responding to your own treatment, whether insecticide or you are putting the source reduction, or you are trying to remove the bleeding sources. So how they are responding it, whether they are shifting their own breeding ground or they are shifting their, they are adapting to different ecological situations. So same way you should have the idea in the draft document that yes, surveillance strengthens and it is strengthened by these measures, and this is the significance. If we don't do this, we are not actually, we are lacking this kind of data. Then the another significance is, if we know that what kind of vector, what is its response, then only we can take proper vector abatement measures. How to attack this vector? I have been always giving an example. If somebody is to do the robbery, he will do the Reiki. He will understand. He will study for months together. When the house owner goes, when the wife goes, when the children go, when the servant goes, what time the vegetable vendor comes, what time the room is locked, what time the house is locked, how many doors they are having. So they will do the full kind of Reiki, which is told in basically a psychology classes, that what is the psychology of a thief and what is the psychology of a robber. Same way, as an entomologist, we have to study the vector behavior dynamics completely, and that is what the importance of the entomological surveillance comes in between. Unless you study what we are doing, we are taking all the historical data based on the knowledge we have, our ancestors, our predecessors have generated. We are taking those data and then we are utilizing those data. We are trying to mix and match, and then okay, this will work. Sometimes it works, sometimes it works, sometimes it may not work also. So when it does not work, we have to do different options available within our feasible tool. We should take it like that. Now, the third option is, this is responsive vector control tools. But if you are doing preventive vector control tools, you should have in mind that what are the preventive tools available. If you are doing, I mean, it will come tomorrow or day after tomorrow. There is a 2-3 slides when we are discussing detail on the vector control tools and technology. It will come that what are the tools which are actually for prevention, what are the tools which are available as a responsive mechanism. Like for surveillance, you have got proactive surveillance, you have got reactive surveillance, you have active reactive case detection, you have active proactive and then routine passive case detection. So there different terminology has been used. I mean, when the case has occurred, basically, when you have found out that there is a mosquito, there is a transmission season already established, there is a transmission going on, you are going to attack, that becomes a responsive vector control measure. When whole year you are doing, like for example, the third figure, it is shown as a mosquito net, LLIN, or any mosquito net. So if you are using it whole year, you are not every day you are being bitten by the mosquitoes. You are not being bitten you are not taking a chance. Basically, this is a preventive. So this is one of the core strategy, LLIN, on the vector control, which is very, very important for the preventions of the, and it not only that, it helps in boosting the total approach on this prevention. The significance, if you are taking the preventive measures, say for example, LLIN, this is basically prevention and control both, because it is a LLIN, this is treated with insecticide, long-lasting insecticidal treated nets, LLIN. Some people, they pronounce it a little wrongly, long-lasting insecticidal nets. Or in WHO, only one terminology is used. They use insecticide-treated nets, which includes the earlier manually impregnations of the insecticide treated nets or the LLIN. So they use everywhere ITN for both the things. Now, what is happening? This vector control strategy, this contributes significantly. This is basically, they are preventing the person who is sleeping inside, and they are preventing and they are killing the mosquitoes which are coming in contact. They are reducing the longevity of the mosquito. So that is why this is taken. This is the significance. You can always say a few lines on your strategic plan when you are documenting. The another core intervention is indoor residual spray. Indoor residual spray protects the community at large. This is very, very important, provided it is done with a quality spray. Patchy spray is not going to help. It is going to damage, actually. That mosquito will take blood and get some spots to take rest, which is unsprayed surfaces. So it reduces, it protects the community also, because in mass the mosquitoes will come and they will take rest, whether they have taken blood here or they have taken blood there. So if they take rest, they will pick up the insecticide and the longevity will be. In addition, definitely there is a personal protection. So both LLIN and IRS, they are taken as a core intervention for adult control. Look here, this is another example of vector control. Even in this area, top right, if you see, This is open hut where people have been sleeping. This photo I took in Jharkhand, some remote tribal belt. See, this area also people are very used to of using mosquito bed nets. LLI, long-lasting insecticide, which is insecticide impregnated. If they are sleeping, it is almost outside. It is not a closed hut of 5 walls, roof and 4 walls. But they are using. So even if there is an outdoor biting, they are using inside that shed. They are using bed net, they are protected. So the vector density is also affected. And they are good for, here, as per the technical terms, neither it is endophilic nor it is exophilic. Nor it is endophagic, nor it is exophagic. It is basically a mid-term can be used. There is no terminology for that. So all the 4 walls are open. There is nothing. It is only a hut. It's only a veranda sort of things. But people are, most of the time, they are there only. But they are using bed nets. That is what bed net was hanging actually on one side of this. It's not come properly in this. The purpose of showing this photo was that it helps in reducing, and that is where the importance is there, that these vector control measures are basically a core survey, a core vector control tools. Now coming to the vector control components, we all know that what are the main vector control components. If you take this, if you see, it starts with source reduction. The first one, integrated vector management. All the vector control tools, if you have the tools, you have to take a rational decision process, making process, that becomes the integrated vector management. Integrated vector management per se, it is not a tool. It is basically a rational decision making process. It is an intelligent, where the entomological intelligence has to be used, how to do which tool, where it is applicable. So here we are just showing all kinds of tools which are available. If you start from the source reduction, which has been since long, if you see channelization, proper breeding, because margin is cleaned and margin flow is maintained, there will be no breeding. Removing the water hyacinth plant so that the mosquito at the bank edges of the ponds, they are not able to breed, especially for the vectors which are breeding. And then the leakage or the outflow of the hand pumps. If you see, it is coming and then there is no drainage proper system. So it will be, initial water will be absorbed, but then there will always be some kind of water which will be there. Good for Culicephaces, good for subpicters, good for these. So many malaria vectors also. Then how you are doing the source reduction for this? Second one is, if you do proper channelization, you do proper building, proper drainage, proper system, proper removal, weekly or fortnightly. So basically a cleaning of the margin. Then there is biological control for the larval. If you see the fishes, larvivorous fishes, there are 10 or 11 varieties of exotic fishes with a larvivorous capacity. But basically gambusia and guppy, what we say, the mosquito fish, gambusia and guppy, they are very common. They are sturdy fishes. They are used voracious larva feeders. And then there are anti-larval chemical insecticide which are used in that area. And then for adult control, if you look on this, they are using mosquito nets. They are doing indoor residual spray. For outbreak response, they are using this space spray, fogging, outdoor fogging, indoor fogging, whatever way it is there. There's one thing that WHO has not recommended for malaria per se, the outdoor, fogging. But many of the places they are using, they are continuing for dengue control, but they are continuing. It has been in use for the malaria outbreak response mechanism also, especially in India also. It has not been yet removed from this policy because it helps especially for the epidemic outbreak containment. Then there are capacity building, different level, different kind of structured capacity building. This is at the village level or school level. When there are community volunteers are being addressed, they are asking some questions. So state level, district level, program implementers, and then at the grassroots level, at the village level, at the municipality level, there is a structured training program. Simultaneously, there is an advocacy program. If you look here, there are villagers which are given in a community advocacy. In the local language, they are given explanation. They are given a special compensation, special package for interpersonal communication. Then advocacy at different level, at the community level, then at the school level, then at the municipality level, then at the district level, then program implementers, the administration at the district level, then at the block level, then at the state level, administrator, bureaucrat, policy makers, local leaders, even media sensitization is very, very important. So these are all the part of this, and this whole thing integrates, and then a package is available. You have to choose using your own entomological intelligence. You have to choose which will be feasible in your area. Please do that. So this is how, whatever I am telling, this has to be a part of your strategic planning. This is very, very important aspects. And then how to maintain the environment so that there is no regulate the judicious use of insecticide. There is no irregularity observed for such kind of things. So for that, how to use it, how to supervise it, how to maintain, how to dispose it of, all those things are actually, it comes under environmental code of practices, and that should be part of your entire thing. So that is very, very important to all. And for if I talk of India, everything is available on the program website. It is also linked with the ministry website also. The same, I'm sure that these are all available at the this such similar kind of things are available in different countries also. Some are not available. Yes, I know the experiences of different countries, so some are not available. Now, if you look on this graph, when you are talking of tools, combining the tools for the taking a decision on integrated vector management, this is one situation which we may arise, and this you should explain in your strategic plan document when you are framing. This is little more complex, but you see malaria is in the center, that blue color round circle. If you see, we have given all the lymphatic filariasis, visceral leishmaniasis, dengue, chikungunya, and Japanese encephalitis. If you see this chart, what are you doing in entomological, based on entomological data? What are the vector you are monitoring? Vector density, you are doing breeding potential, you are doing infectivity for lymphatic filariasis in the vector. But what are you recommending? Basically, it is a QLEX transmitted, so you are doing sanitation, characterization, then of the breeding potential, then stormwater drains, flow maintenance, minor engineering, larviciding, and supplementation with LLIN, because it has a collateral benefit if you are putting yourself inside the bedroom. If it is a Mansonia transmitted Brogian filariasis, you are actually maintaining sanitation. Major focus is on environmental engineering, removal of the water plants, hyacinth, so that there is no Mansonia breeding. But if you see on visceral leishmaniasis, you see what are you doing? Again, you are monitoring vector density. So, and see the entomological surveillance, how important for framing the vector control operations. Because you are doing vector density, you are also monitoring microclimate conditions for phlebotomus, and then you are using quality IRS with change frequency. Maybe you are because the transmission dynamics is a little different. So you may not cover the entire transmission period when one go. So you can break the spraying season 1 in 2-3 months, and then giving a gap of 2-3 months, and then doing the spray. If you look for the dengue arboviral disease, dengue, chikungunya, and Japanese encephalitis, sorry. If you look on this, what are you doing? We are doing entomological monitoring on vector prevalence, larval survey, larval to adult identification. Then we are finally coming to the whether it is an albopictus or it is Egypti. So means larval indices we are monitoring, and we are trying to eliminate the breeding potential, basically for all Aedes breedings. Then, because there is no vector control as such, it will work, and there is no drug also for that. Now some people are doing trial with the residual spray operation, targeted. They call it as a targeted indoor residual spray operations. that is up to 1.5 meter only, but it's still in the program, it is not. Then for Japanese encephalitis, if you look for this, because this is basically Culex tritonorincus vishnoi group. So what we are doing, we are monitoring larval, we are seeing breeding potential, we are seeing vector density. So these three things we are doing, and then we are delimiting the area. We are trying to do the outdoor fogging for spray and spraying in the pigsties. But you see, larval monitoring, adult monitoring, breeding potential monitoring, these are three things with different parameters in different vector-borne, mosquito-borne diseases and the sandfly-borne diseases. But what basically comes out? Malaria, we are doing little more. We are seeing vector prevalence, feeding behavior, host preference, biting, resting, infectivity. So, in addition, breeding potential, larval density, everything is common. What I want to say that Malaria has given lot of entomological surveillance guidelines for taking help in other program, other vector-borne diseases also. But it consolidates on the larval control, on the adult control, and with the outbreak containment response for the fogging. Now, if you see on the last below chart, if you see, we are doing breeding of mother foci, as I was discussing, telling about the microgeographic condition in Stephensi, urban areas. Then we are doing breeding plus adult density plus seasonality for malaria. So LF, then malaria, then visceral leishmaniasis, and then malaria. We are doing malaria. We are also monitoring entomologically vector daily survival, infectivity, and resistance monitoring we are doing to see the response of the insecticide to select the proper. Then we are doing seasonality, trend analysis we are doing. But ultimately, we are trying to see the transmission potential in areas which is being monitored. And this becomes the key. So transmission intensity from the basic epidemiological data and transmission potential from basic information generated on entomology. If we club together both, we try to assess this area is more on the red zone or the hot zone, that because of cases are there, vector potential is there. Multiple vector, single vector, potential vector, less potential vector. Or the area is not there with the cases, it's a low endemic area, but vector prevalence is there. The third one is neither malaria cases are there, nor the vector is there, but there is a area is vulnerable, area is receptive, or completely gone, area is gone. Then we will proceed for the next one. The showing this chart is very, very important for strategic plan formulations process, because we have to justify and show this. This is basically taken from a WHO document framework, which was given in 2017. But I have translated into this. This is basically a statistical assumption graph that if your efficacy is 98% and every step there is a decay from 98%, if you are getting 65% out of that, if you are doing 95%, 90, so every step there is a sequential decay in performance, you are actually getting 37% effectiveness output only from 98%. To understand little more, if you look on this chart, especially designed for our vector-borne diseases, if you are, say, for example, you have planned in a strategic plan, you have planned for 100%, you have made a budget planning. If you are getting 100%, you have planned, you are getting 50% of that. Out of 50%, so 50% it is here. Out of 50%, if your performance is very good, if you have done 80% performed, whatever you have been given. So out of 50%, 80% means actually your output is only 40% against this. Because ultimately your entire thing will be just what you have planned. And this 80%, whatever you are access given, you have utilized 80%. I mean, you have been given 80%. So again, 40% which you have got, actually you have got 32%. And then whatever 80%, 40% you have utilized, actually you have got 32%. This 80%, whatever resource you have been provided, if you have very nice, very good implementer, you have utilized 80% of that, which is supposed to be one of the very good judgment cycle for this utilization. Then basically you are actually achieving 25.6% only. So your output is basically 25%. See in another chart. If your performance is further good, instead of the previous chart where you have been given 50% resource allocation, if you are given little more, if you see out of 100% planning, if you are given 80%, and out of 80%, you have got the excess of 80%, right? And you have utilized 90%, which is very good. 90% if you have done for implementation of the plan 80%, your output is only 46%. This concept has to be given in the mind of the people who are actually governing the whole system. This is very, very important chart, which I have tried to make it very, very simple form. And that is how I wanted to emphasize on the chart that this is the crux of the entomological intelligence or epidemiological intelligence, which we should have in mind, that we have made some budgeting with great difficulty, with great brainstorming sessions. But if you don't give or don't allow, and for on paper only it remains, you are not going to have this. Now, the last point which we wanted to discuss is the elimination certification process. See, we have not reached to this level. So we have to follow the WHO guidelines, and with whenever we are making our plan, we have to see that whether entire in toto it is applicable, or if something is to be little bit modified, we have to justify. But as on date, we have to follow as it is the WHO certification guidelines, which starts basically from subnational verification, which I have been trying to tell in the earlier, that subnational verification is basically small units which have to generate the documentary evidence and then make the whole pyramid that yes, now we are ready for the whole country. That is what the subnational there is a system, there is a process of subnational verification, that at the block level, at the PHC level, primary health center level, people, the working unit heads, they will see their own data analysis, their own reporting. That is why the first two slides, surveillance and data reporting, the reporting system has to be taken as a core, and everything is revolving around that only. So situation subnational verification has to like a building block. So every block, every unit, smaller unit has to generate the data and claim, look here, we are free, we are free, we are free. Now we are making a building block, and then only the whole prism will become. Then the whole country, they will assess the situation, and once it is satisfied, they will go for the independently, they will be evaluated. They will try to get it evaluated by experts. And then once they are satisfied, finally, they will approach WHO to give them. What is that? 2017 framework says that country will submit the official request after 3 years with 0 indigenous cases. So means 27, if we are targeting 2030 beginning or 2030 end, after mid-year, we will submit a report. We will request to WHO. Then country will formulate the plan. WHO will assess. WHO also has got their own committees and systems. So they will also take some time. Look here, the certification elimination panel they will form, and then they will submit a final report. They will see the data, they will see the document, they may come to verify, they will, then Malaria Policy Advisory Committee will see, they will recommend. Then finally, once they recommend the impact, then only it goes to Director General of WHO. And once it is approved officially, then the country will be certificated. But to look on this chart, you see, there was some nomenclature changed in 2022, which is, this is the document, second edition. This is given changes in nomenclature. It actually, if you look on this, the framework which was updated, it was based on 55 and 1969 malaria program data. To make it more simple, I will say that in eradication phase, we were using 4 terminology. Attack phase, that is pre-elimination phase. Then consolidation phase, maintenance phase. So that is all category 1, 3, 2, 1. and then coming to zero maintenance phase. So that is how we have taken the basis from the eradication era and certification elimination panel, which I was showing earlier, 2017. Now that name has been changed as a Malaria Elimination Certification Panel, MECP. There's nothing. The same committee will evaluate this, and MECP was renamed in this document, which we am showing now left hand side, preparing for certification of malaria elimination. This name has been changed as a Technical Advisory Group, TAG-MEC, Technical Advisory Group on Malaria Elimination and Certification. So you should have in mind all those people who are working for malaria. They are at a different level. They should understand that now it is all the same CEP or MECP or TAG-MEC are the same group which are actually verifying our claim and seeing the data. This is very, very important. This is the whole process, and I think this is the last slide of my presentation, that you have to go like this step. And if you very, very sorry, because it is taken a photograph. So last indigenous cases, if you have taken here, say 27, or maybe some subunits, they have taken 22, 23, 24, 25. So they have to maintain 3 years, 36 months, zero indigenous cases. And then they have to submit an official request, whether it is for subnational committee or there is for. So then there will be, see, self-assessment of this. So once they submit the official request, then they will verify here, and then finally the national elimination report will be submitted. Then the TAG-MEC, that is Technical Advisory Group, and for Malaria Elimination Committee, they will independently evaluate, or they may depute some mission, independent mission. They will come. This is all WHO part. So this is all country part. So then this TAG-MEC report will be submitted. They will do the review, and then your MPAC, Malaria Program Advisory Group, will see their recommendation. They will review. Then they will submit to DG, and then the final decision will come. Then this country will be certified for malaria elimination. So this is for today. This is for all. This is the basic concept. I'm sorry for a much brainstorming session. Thank you. Thank you.
That was a masterly performance. My golly goodness, well done. Absolutely wonderful, very clear and confident presentation that reflects decades of experience. And it's not just the experience, it's the ability to convey that wisdom that's been accumulated over all those years, the understanding and, conveying that message. I want to congratulate you and thank you, Dr. Pradeep. Very well done. Absolutely highly enjoyable, very informative, very instructive presentation. I think that we have all benefited from. This is my second time now, last year, now this time. And every time you discover new elements and learn new things. So from me as well, and all of us in the audience, sincere thank you for that. Personally, I found it very interesting, that decay process, which you explained so nicely. You may start with 100% planning, and so on, but the impact, goes down to 46% or 25%, depending on, how effective you do the intermediate steps. But very, very important factors to keep in mind, that your planning may be perfect, but depending how effective you are in resource accession and implementation, the eventual impact is usually much, much lower. So I want to suggest we have 4 questions in the Q&A box. Let's do the submitted questions first. Dr. Sharma, I saw you had your hand up. Please allow us, these people who submitted written questions, to be fair to them, let's respond to them first, and then we'll ask people to raise their hand, and then they can vocalize their own questions. And you will be first, Dr. Sharma. Nice to have you on board. It's good to see your name. Thank you, Dr. Sharma.
First of all, congratulations, Dr. Leo and FMN team for this virtual course on strategic planning of vector surveillance and control, particularly elimination settings. So first of all, congratulations to all of your team, and very good presentation by my friend Dr. PK.
He is my colleague only and friend. We are all together. We are
so apart from this friendship, just I want to say one thing about particularly Stephensi and Aegypti mosquitoes, which are container builders particularly. When we are talking about our region, so apart from urbanization, there is a industrialization also going on in different countries. Industrialization going on, and there is a huge problem of Anaphylaxis stephensi as well as Aegypti. So if we are doing entomological surveillance, effective entomological surveillance for particularly one species, example, container breeder, Anaphylaxis stephensi, positively we will get very good bilateral benefits for Aedes aegypti also. So now this dengue is going on. So my submission is that this I supplement. He has covered all these things. Dr. PK has already covered all these things. So I want to say that when we are talking about integrated vector surveillance or entomological surveillance, so some countries, malaria department is separate, dengue department is separate in our region, the Southeast Asian region. So integrated vector surveillance means if I am going for a particular entomological surveillance, so I have to cover Aedes, Anaphylaxis, Culex, or all particularly vector species. So problem is that like Sri Lanka, dengue outbreak is going on. Other side, malaria elimination they have already achieved. So though there is no integration for particularly vector surveillance. There are two different departments, separate departments. Yeah. When you are talking about entomological surveillance, so this is my basic supplement. Nothing. There is no question. So countries which are having different departments, so they have to also integrate it, their own activities, particularly for entomological surveillance. Thank you.
Dr. Sharma, thank you for that addition. Very helpful. Again, lots of experience from your side. Thank you for sharing that information. So if we go to the questions now, and
I'm seeing it question. Can I start answering one by one?
Yeah, sure. Okay. Okay. Go. Would you mind reading the question first?
Yes.
And then responding.
The first one which I am seeing is that Agai Kumi. To my computer, the first one is coming as a. There are 4 questions I am seeing.
Correct.
Okay, so the first one is, if I get you right, entomological surveillance alone is not enough, and that epidemiological data should be added. In case where there is a lack of resource for both, which one will be advised we prioritize? The answer is the first one is epidemiological data is always available, whether it is at the state level, district level, or primary health center level, or block level, whatever system is there. Because fever surveillance and detection and treatment and case management is going on everywhere. The only thing what we are lacking or we are varying is the entomological surveillance. There are vector control people, whether it is in a structured fashion or it is a fragmented fraction, it is available to some extent or the larger extent. So I have already told in one of the slides that basic stratification when we are planning is done based on the epidemiological data, case load, magnitude of the disease problem. If you are taking 190 countries for malaria elimination, the country we are not malaria problem, they are not included in the malaria elimination target. So basically the first target is that you have to have the case load and the malaria cases. If you do not have the entomological component, that is what the strategic plan emphasis is, that you should have entomological surveillance and you are making a plan for that. So the simple answer is that you have to justify, emphasize, and put it in a strategic plan for malaria elimination if you are actually targeting. Without both the components, you cannot prove yourself, your country cannot documentarily evidence that you have achieved this success. That is the answer basically.
Excellent response. Yeah, wonderful. You need both. Second question, are you going to? Yeah, okay.
Second is the Nantha Kumar Jai Prakasham. Thank you, Dr. Pradeep. Now, WHO is also considering the numbers of zoonotic malaria cases when coming to malaria-free certification. Are there any specific guidelines on the certification of countries for countries which had eliminated indigenous human malaria for past 3 years but facing high prevalence of zoonotic malaria? Secondly, in your opinion, any possible control measures for vector of zoonotic malaria? We are talking of human malaria, and recently only novel sai has been problem raised in, and there are now cases that are coming up for novel sai. Novel sai has been prevalent in earlier time also, but because only 4 parasites were considered as a human malaria, which are being transmitted from human to human, now this novel sai has come out this. So parasite clearance, you have to take only the parasite part. But when it comes to the entomological part, you have to emphasize that you have to add all these 5 parasites in your strategic planning as per the recent WHO incorporation guideline, that now we have to show novel sai also as one of the one of the 5 parasites component, and then we have to make a plan. And basically there is no specific guidelines. It is all basically isolation of zoonotics and then keeping the track of this, because as such in many of the countries still there is human to human transmission is yet to be established at the national level. Then the third one is Ajay Tripathi. Should India or any state follow WHO malaria vector control guidelines strictly, or we can be flexible? In any country, you have to, Mr. Ajay, in any country, you have to follow the country guidelines first. Though we all know and we understand, and I am in that committee, myself and Harish Sharma and all many people, that it is WHO guidelines, which is a general in nature. We have to take a cognizance of those guidelines. But ultimately, national guidelines are developed taking WHO partner, WHO technical guidelines, and WHO as a stakeholder, major stakeholder, as a technical guidance partner. But when there is a national guidelines, you should follow that instead of jumping to the WHO guidelines. That is what the regulatory framework for any country. Then there is another one is Dilruba Sahareen Kabir. Dr. Srivastava, can you briefly say about the outdoor and indoor fogging procedure and how long it remains ineffective? This is actually in another session in detail for the fogging, but because to answer you, let me say that outdoor fogging and indoor fogging, basically for malaria, it is recommended only for outbreak containment and response. It is early epidemic preparedness and response mechanism. It's not recommended for a routine thing. Number one, basic concept of fogging is that you have to reduce the epidemiologically dangerous agent mosquito. When the mosquitoes carrying sporozoite for malaria elimination, they are much more in number, and you expect that there are more transmission will go immediately. You try to do the fogging at the time when this is suitable for that. Outdoor fogging is done only the morning and evening when there is a swarming time for the mosquitoes, when they are coming in the batches and big ground, so that you try to attack on those for in the air itself. Indoor space spray is done. Basically, it is more effective for the indoor rester like dengue vectors and Stephensi vectors in urban area. It's not recommended for the rural area. And very important point for indoor fogging, indoor space spray, the safest one is pyrethrum extract 2%. Recently, there is one synthetic pyrethroid, cyphenolthrin 5% EC has come, that is recommended, where outdoor fogging is done usually with the malathion technical, but that was recommended only for Japanese encephalitis because primarily they are outdoor feeder and outdoor biter. Then there is another one, this Dr. Ismat Imami from Afghanistan, MBD. As we all know that approximately 95% of malaria cases in Afghanistan is PV. Is there any specific elimination strategy? That's it. Important one is that complete treatment, and the 3 years basic concept was taken from PV only, my dear, because PV relapse and recrudescence we see only 3 years. So basically 3 years, whenever you do attack, PF comes down faster, PV takes 3 years to go. That is an epidemiological paradigm which we have studied. So PV, complete treatment, complete radical cure, which is little more difficult for 14 days radical treatment with primaquine. And then you have to have the total vector control plan for test, treat, test, track, and treat. Complete tracking of the individual cases so that there is no relapse and recrudescence, and the imported cases you have to die. There may be some hypnozoite cases. So sometimes you do mass survey and treatment in the low endemic area to get this gametocide load in the country, and you try to get the asymptomatic cases so that you completely treat and finish off them. And there is one is myself, Vikas Gehlot, zonal entomologist, MCD, wants to know, I got one PF malaria case in Nazafgarh zone last year. I did entomological surveillance and got breeding sites found in an agriculture field, and I treated the site and also did mass surveillance in the area, but no one found positive and no fever case were there. What to do next time if any case reported from there again? What we are the next step? Nazafgarh zone, Delhi, as till now. Mr. Vikas, you are in Delhi only, you can discuss all these things. But anyway, since you have asked here, finding a case and treating the agriculture field will not work, because in Delhi or Nazafgarh area, what is the vector? First, you should try to understand whether your vector was breeding in agriculture field, which you are saying that it has been treated. But anyway, if it is Stephensi related malaria, you have to look for it. Is very difficult to get the Stephensi and find out this. As I have told you, urban, there is a lot of microgeographic condition and micro conditions. If you see the Dr. R.S. Sharma's paper, that there is a microclimate for the Stephensi also. Number one. Number two, if it is a Culissifasis transmitted malaria in periphery of Delhi, you have to work for Culissifasis breeding grounds and try to get the mosquitoes from the cattle sheds, and because primarily it is a zoophilic mosquitoes. So try to see the focus where exactly it is. And then you should try to treat that area where the breeding source mainly for Culissifasis is coming. If there is any other vector, you have to highlight which kind of vector, because vector biodynamics is very, very important. Then another one is, I'm here to again asking a question. Dilruba has come again, entomological evidence of control phase, obviously an important component to get certificate. But if there any lacking in documents, how can it be recovered and aligned with epidemiological data and documents? This is a real challenge for lack in entomological data, but it all depends on the WHO technical team who have to see. That is why still not, even 24 is not that late. Even now, if you start entomological strengthening and this coming strategic plan, you really generate the entomological data. You have to fix the sentinel sites, which I'll be talking in the subsequent sessions tomorrow or day after, that when you are trying with the resource constraint, how to fix the sentinel sites and spot check sites. That is very, very important. So still 5 years, 3 years left for 27 and 6 years left for 30. So you can always have lot of data generation on entomological. Even in the remote area, you can have little restricted sentinel sites, but it should be representative, which I'll be talking in detail, and hopefully I'll be answering in detail there. Thank you. There is another one has come. Which factor trigger most about the container breeder changes their breeding? I know this shows the interest of the people. I'm thankful. Which factor trigger most about the container breeder mosquito changes their breeding? This is their habit, that they require fresh water breeding. They want fresh and stored water. That is what the biodynamics study. If there is any change, we understand. We have to study the entomological. There is an ecological section. I can give you one example for Culissifasis in northeastern states of India, where Culissifasis was not being recorded. Now it is being recorded. So by and large, as on date, it is basically a fresh water, stored water breeder, Stephensi, which is an urban malaria, and that is what the invasion is going on. There are two types, basically, wild form and mysorensis. So type form and mysorensis form. So mysorensis form, type form only is the vector. Mysorensis form does not breed in container, it breeds everywhere. So you have to have that kind of knowledge, and that is what it comes from the binomials. Thank you. Thank you, Leo. It is over to you.
Thank you, Dr. Pradeep. I see, shame. Smita Rawat has had her hand up for quite a while. So before we go back to the written questions, let's ask Smita, please turn on your microphone and ask your question. You're welcome to go ahead. Smita Rawat, please. But you need to activate your unmute yourself, please.
Thank you for the lucid presentation, Dr. Pradeep. Dr. Smita Rawat from the regional office, Bangalore. Can you hear me? Am I
Yes,
audible?
yes.
We can hear you
Good
clearly.
afternoon,
Please go
madam.
ahead.
Good afternoon.
Yeah.
Good afternoon, sir. It was a great presentation. I had a few doubts, which I thought would you would be the
Please,
best person to clarify. So this was regarding the follow-up smear of a positive case. What are the country-specific guidelines, sir, on that? For a malaria positive case, PV and PF, what should be the follow-up smear time, sir?
Country specific guidelines is very shortly coming. We have highlighted in national strategic plan that because there was some variation. See, if you see the old documents, follow up, there was 3 days, then 7 days, then unfortunately, then 27 days. Now we have streamlined it, and it is coming that at least 3 days after first follow up, and then 7 days. So it is coming on the national strategic plan. Just have a patience. It will come as a country guidelines. I don't want to leak here this information. Thank you. But technically, yes, it is 3 and 7.
3 and 7. Because there were lot of altering this thing that I could get an idea of. As
No. For idea sake only I am giving, but just wait. The country guidelines is the regulatory framework.
Okay, so I think that document would be really helpful, sir. And also, sir, similarly, like when we, there is if this is a case scenario, there is a PV positive case, sir, in a urban setting, studying in a college. Most probably, I feel it may be Anopheles stephensi, which should be the vector, right? In an urban setting, studying in a hostel. But this person is tested positive, but none of the contacts are positive, sir. And there is no breeding also. So how would we, go about such a case in classification?
There are many
no
reasons.
history.
There are many reasons, Dr. Smita. When we joined the services in 81, I was living in Connaught Place and I got positive PV. My co-mate did not get. We were 4 people. They were living in one apartment and none of them they got positive. We were working, so we had a full access. Every month we were getting our blood slide screened. Nobody was found positive. So maybe we are at workplace, we might have contracted the disease. Or maybe some other place we have contracted the disease. So that is what the earlier epidemiological investigation form, if you see, it used to be 7 pages. Now it is only 1 page. So you require only very limited information, and that is what the challenge is. But the problem of the public health program and elimination strategic formulation plan is that whatever regions you have traced that there is one case, you have traced that contact is not there, so the foci is not there. So you have followed the case, contact case, and case investigation has been done. Foci is actually non-active. So it means you have to track and treat the case only.
Smita,
give chance to others.
Yes, Smita, let's give someone else a chance. If you have other questions, come back. Let's just move around the audience to give more people a chance. But you're welcome to ask more questions in a short while. So, Dr. Pradeep.
Thank you. Thank you.
Great pleasure. Thank you for asking that, Smita. So there's a Naimul Hassan. This is an interesting question about BioQuip seems to have shut down, and some people relied on BioQuip as their entomological supplier of choice. So some people are struggling to find access to buying equipment. Do you have any knowledge about suppliers that people can look up on Google or something
That is what is the question is that Dr. Pradeep, can you be able to provide suppliers for smart or IoT internet of things based mosquito surveillance traps from the globe?
Yeah,
I tried
I
hard.
struggled a bit to understand the question as well, but my understanding is just looking for guidance as to suppliers of mosquito traps for surveillance.
Yes, yes, there are many kinds of trap, but so far as traps for the elimination strategy, it has not been taken as one control tools or elimination tool, vector control of tool options. It is basically so far all the traps are taken as a study purposes, the research purposes, or in case of dengue, yes, it can be taken as a surveillance tool. In addition, now the lethal traps are coming, but it has not been taken because there are a lot of issues involved. When you are taking into a public health program, try to understand what I am saying, that you have to have the first thing is that you have to have the manufacturing, you have to have the need assessment, you have to have the replacement cycle, you have to have so many things are there. I mean, it has not been taken, and then they have to come to the program with through the regulatory body, that whether this can be accepted as a vector control tool, or it can be accepted as a surveillance tool, or it can be accepted as an operational research tool. So far as operational vector control tools, it has not been accepted, as under my knowledge goes.
Yeah, no, absolutely. Thank you, Dr. Pradeep. Naimul, if I understand you correctly, your question is actually very straightforward. You would like to know the address or name of a supplier for traps for vector surveillance. Some people used to rely on BioQuip. My understanding is BioQuip is shut down. So, you know from the literature that CDC light trap is a very commonly used trap. So just go to Google and type in CDC light trap suppliers and see what Google tells you. Of course, there are net traps and so on. Those you have to manufacture yourself, by and large. So I think just go into Google and do searches on net traps for mosquito surveillance, or CDC light traps, or BG gat traps, or things like that. Just type it in there and see what you come up with.
That's right.
Yeah, actually, Dr. Leo, actually I tried hard on Google, but still I didn't find any reliable supplier on commercial for commercial purposes.
Yeah. All right. Naimul, if I know, it's just on the tip of my tongue. I can't think of it right now. Lumin 8, LUMIN 8. It's a shortening of Luminate. But if you type in LUMIN 8,
Okay.
it should give you the name of it's an upgraded, more robust version of the old CDC light trap.
CDC light trap upgraded version. Yes.
Yeah. So, and it's a South African company. I've used that trap for quite a long time, and it's very reliable. A little bit on the expensive side, but it's robust. It will last you years, and it's very effective. I don't know of a unfortunately, I don't know of a company that produces CDC light traps. If somebody in the audience does know, maybe you can pop in a URL on in the chat box for us. That would be very useful.
Yes, I
Yeah. So
Yeah, that's the reason I provided my email ID. So if
yeah,
anyone has any link, you can share. It will
that
be
would
a
be
great
great.
help
Yeah,
for me.
absolutely. So are there any other questions? I don't see new questions in the Q&A box. Maybe I've missed some hands up. Are there any hands up? Otherwise, I'm going to ask again, I'm going to thank Dr. Pradeep for a wonderful, wonderful set of lectures. It was really great. But Dr. Pradeep, please give us an appetizer, some idea of what we can expect tomorrow, if you don't mind.
Tomorrow, just a moment. Yeah, there are so many things going on. Just a moment.
Yeah. I'm sure most of our audience will be linking in again tomorrow. Just as a reminder to the audience, the proceedings, the event is being recorded and it will be shared on the www.oreen.org website. That's www. Oreen is ORENE website, and it stands for the Online Resource Exchange Network for Entomology. So www.oreen.org, you'll find the recording available. Dr. Pradeep?
Yes.
Oh, you're still looking, yeah.
So, basically, our entomological intelligence monitoring and surveillance, entomological surveillance total framework. So we'll be discussing about on the transmission dynamics in different situation, and then we will be discussing on that. I just wanted to share that screen. I was looking for that. Why it is not coming? That is what I'm saying. Yes.
Oh,
now it is. So we will be discussing on entomological intelligence and vector surveillance planning framework, how we have to do in vector surveillance and in what situation, what will be the basic framework for vector surveillance. And that is what entomological intelligence basically means. So we'll be discussing on that.
Wonderful. So our audience members, there's another 2 hours of a journey of discovery into entomology and vector biology and disease control. Please join us tomorrow afternoon and listen to the words of wisdom from Dr. Pradeep. It's been a most enjoyable event today. Thank you everyone for your attention, for your participation. Very grateful indeed. We'll see you tomorrow. Please
Thank
join.
you. Bye-bye.